Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center. Today we continue the Whipple procedure tutorial series and talk about Whipple procedure survival. I am frequently asked by my patients, and a very common Google search is on Whipple procedure survival. Today's tutorial will try to elucidate some of the data surrounding this question. In order to answer the question of the survival of patients with pancreatic cancer who have Whipple surgery, the first point that must be elucidated is short-term versus long-term survival. When surgeons speak of operative survival or 30-day operative mortality or short-term survival, we're talking about the survival from the operation in and of itself and not necessarily the disease process. And I think that this is sometimes a confusing term for patients in that sense. So when speaking with patients on what is the survival or what is the success of the Whipple procedure, or what is the survival rate, most series show that operative mortality is for Whipple surgery is now under 5%. We've come a long way since the 60s and 70s with the early years of the Whipple procedure. In other videos I describe the complications of Whipple surgery as well as some of the reasons why the morbidity is high. But by and large, under 5% of patients have an operative death within a 30-day period. At St. Joseph Medical Center in the past 5 years we've actually had 0 deaths, and our operative mortality in general since the inception of the center is probably in the 1% range, but nationally acceptable mortality is under 5%. Clearly, patient selection is what is important when you perform Whipple surgery, which is a complicated operation on patients who have significantly more comorbid risk factors such as heart disease, lung disease, etc. Your chances of getting them through the surgery is more difficult. It is a complicated operation which takes about 3 to 4 hours in our hands, sometimes longer at other institutions, with a lot of complexity involved. So performing the Whipple surgery with a mortality of under 5% in the 30-day period is what is probably standard. Long-term survival, however, assumes that the patient has recovered successfully from the procedure and reflects more on the biology of the cancer and whether or not the surgery plus the chemotherapy and radiation produces a cure. And I'm going to review some of the data from different institutions as to the survival in the long term. We'll just start with some basic statistics from several published large series, and I'll summarize them. Patients with adenocarcinoma of the pancreas who have successful Whipple surgery have a 5-year overall survival, anywhere from 10 to 20% depending on the series. Now, more recent series with more sophisticated chemotherapy and radiation, which is also inclusive in the treatment, it's not just the surgery, tends to show that the survival is probably somewhere between 15 and 20% in modern series. And we use 5 years as what we consider potentially cured or closer, or the cure rate. If you make it out to 5 years, it's not a 100% chance that you're cured, but the chances of cure are greater. So as you can see, with adenocarcinoma of the pancreas, patients who undergo Whipple surgery plus further treatment, which is either chemotherapy alone or radiation alone or chemotherapy plus radiation, overall survive 5 years only in the 15 to 20% range, meaning that the majority of patients, or greater than 80% of patients, are not cured. We also use the term median survival to basically give an idea of the survival after surgery. And median survival for pancreatic cancer in patients who have had either Whipple surgery or other types of resections are in the 18 to 20 month range. So what are the prognostic factors that we can help determine where you may lie? And I'm going to go over those prognostic factors right now. So the prognostic factors that determine survival, number one is the lymph node status. During Whipple surgery, we generally take out somewhere in the order of 15 to 20 lymph nodes as part of the specimen. We do not routinely perform extended lymph node resections, and I discussed that in a separate video. The size of the tumor is important. Generally, these cancers are usually in the 2 to 5 centimeter range. When they start getting over 5 centimeters, they're generally not operable. And the last factor is whether or not the entire tumor was removed, and so what we call that margin status. So are you an R0 or margin status negative versus an R1, which is microscopically positive margins, versus an R2, which is just gross tumor present at the margins. So the best data to look at as far as numbers is probably the Hopkins data. Since over the past 20 or 30 years they have performed more Whipple surgeries than any other institution. And in 2007 they published in a journal called Surgery a very good kind of review of this topic with regards to lymph nodes. I think it makes intuitive sense that if you didn't take out the cancer completely and your margins are positive, that you're going to have a lower chance at being cured, unless you rely on the radiation or chemotherapy to cure it, which can happen. Clearly, I think it's also intuitive and quite logical that as the tumor increases in size, the chances of survival goes down. But what's interesting is looking at the lymph node status, and the number of lymph nodes involved clearly portend a worse prognosis when the number is high. Usually, like I said before, that 15 to 20 lymph nodes are examined in the typical Whipple specimen. What's interesting is that only 20% of patients who have surgery are truly lymph node negative versus 80% that are lymph node positive. So the majority of patients do have positive lymph nodes, and the extent of lymph node involvement portends to survival. So I took this data from Dr. Pollack from Hopkins paper that was published in Surgery in 2007, where he cleverly used what's the lymph node ratio and used it to help correlation with survival. And this is median survival over here. I didn't have enough room to write it out. So if there are 0 lymph nodes involved, median survival is 25 months. This is in months. 0 to 20% of the lymph nodes involved, the survival is 21.7 months. 20 to 40%, it's 15 months, and greater than 40% of the lymph nodes involved, it's only 12 months. So it does go down in a direct correlative fashion. I think this information is useful because we do get, since I mentioned, we do get 15 to 20 lymph nodes, and post-operatively it is easy to characterize the ratio of the lymph nodes. And with this data, I think it is useful information to patients because they quite frequently do ask what their survival chances are. How did the pathology look? Obviously, they need to the information as to whether they're R0 or R1, for example, is important. If their margins are positive or not. So I hope this video helps elucidate some of the mysteries of survival after Whipple surgery.